Good evening, everybody, and welcome to the FLCCC Alliance special weekly update. This one is for teachers, and we're glad to have you with us. I'm Betsy Ashton. I'm a former teacher myself. Years ago, I did it. I know what you're up against in the classroom, and I'm now the creative director of the FLCCC Alliance. This is a group of doctors that came together at the beginning of the pandemic to create safe and effective treatments. And they developed two protocols, one early on called the Math Plus hospital treatment protocol, when they used it to save a lot of lives using steroids before the officials out there even said it was a good idea to do. And they came around and proved that the FLCC doctors were ahead of the game and were right all along. And then later, as our doctors started to read studies coming in from all over the world, they saw the value of ivermectin in prevention and early treatment, and they created the iMask Plus treatment protocol. I for ivermectin, mask for the masks, and the plus for a few other things you'll hear about in a few minutes. And this is to prevent the disease as well as to do early outpatient treatment. Very important. And as I said, you'll hear about that in a minute. What we're going to be doing is we'll be here for 30 to 45 minutes. An important disclaimer, though, I have to tell you that this is not private medical practice for you. Whatever you hear tonight is for educational purposes. Discuss it with your own doctor. And, we don't know what's going on inside you. Your doctor does. So whatever you hear, you can use, but it's wise to discuss with your doctor if it involves any medication. And what you can expect, this short welcome from me. Then we're going to have about 20 to 25 minutes from our expert tonight, who is Dr. Eric Osgood. He is the medical director of mission hospitalists at St. Francis Medical Center in Trenton, New Jersey. He's been working in the ICU, saving lives all throughout this pandemic. And he's going to be taking your questions at the end of his talk, which is great. And we'll get as many answers in as possible. First, a bit of housekeeping. Look down on the screen. I see some of you have started to chat, but honestly, if you want to ask questions and get them answered, use the Q&A. That's what we will be checking. If you want a question, put it in the Q&A and then we will get you the answer. Of course, you can talk to each other on chat, that's fine, but answers will be on the Q&A. Now, this is a live webinar, and we are thrilled to have you with us. So we're gonna go right into our special talk. And I wanna share a quote that touched us, that deals with your situation. From a Chicago teacher, she said, "I'm so afraid to go back to the classroom, but if I don't, I could lose my job. I just don't know what to do." Well, we understand that fear. And so I'm asking Dr. Osgood, how can all the good teachers that are watching us tonight protect themselves when you're in a situation indoors where speaking and breathing become a danger?
Thank you so much for having me, and I really appreciate everybody who's joining us. I'm really honored to be doing this. I have just the absolute utmost respect for teachers. I feel a sense of solidarity with teachers. I consider myself to be a teacher of sorts, although my students already have like 20 years of education behind them, and I'm not sort of molding the young minds that teachers out there are. But now we've come to the point societally where we've decided that kids really can't be out of school anymore, but you are the ones that are being tasked to get back into the classroom and teach them, understanding that there's risk. And we're being told that being vaccinated is not supposedly a requisite for teachers to be going back into the classroom. This is the official position of the CDC. Many teachers want to get vaccinated, they can't. And I mean, I remember when the CDC told us that asymptomatic spread of COVID-19 was rare, and they were telling nurses that they could just wear bandanas. And I know that teachers out there, as well as many in the public, don't have a lot of faith in what they're being told, and there's some inconsistency in what's being told. And I understand that, and I just want to try and give you the best information I can give you to equip yourselves with the information you need to try to keep yourselves as safe as possible. And so I've titled this Protection Against COVID-19 for At-Risk Workers, Teachers in the Classroom. Next slide. So who am I? I appreciate Betsy's kind introduction. I've been a physician. I've been an MD for a little over a decade. I've been practicing hospital internal medicine for going on 6-7 years now. So I am board certified in general internal medicine, but my subspecialty is what we call hospitalist medicine. So I take care of patients in the hospital who are sick, hospitalized, and I work in what's called an open ICU setting. So even though I'm not board certified in specialty training, critical care, I do quite a bit of it. I went to Tufts University School of Medicine, and I did my medicine residency at Seton Hall, St. Francis, and I was a chief resident there in 2014. And then I've come back now to work there, and I'm now the medical director of the hospital medicine program at St. Francis. I also have a little bit different of a background than a lot of physicians, because before I did my residency, I spent a few years in a clinical trials unit doing mainly phase 2 clinical trials, as well as what we call proof of concept and metrics and outcomes research. So it's basically the study of studies. So I've gotten a lot of experience that most doctors don't get in basically how to appraise research and recognize good actionable medical evidence when it's there. Whereas most doctors approach research critique from what can we pick apart that's wrong with studies. I'm a little more trained in actually how to recognize when there's things you can use in trials that are a little bit more limited. And that's a big part of how I became a kind of a kindred spirit with the other FLCCC doctors, because all they've been doing throughout this pandemic is picking apart and scouring the globe for the best research they can use to try to find ways to put a dent in this pandemic, save lives, and reduce transmission. And so I just want to say that I am now a clinical advisor with the FLCCC, which is kind of a recent development. I do not have any financial disclosures or conflicts of interest to report. I don't get money from any drug companies. I don't do any kind of work with industry or anything like that. And I have to say, I've been interested in the FLCCC because I saw what happened the first time the world didn't listen to these doctors. And Betsy mentioned steroids, which have turned out to be the one modality when people get so sick in the hospital that can save your life. It's the mainstay of therapy. It wasn't until almost July that the global medical authorities actually recognized this, whereas the doctors in the FLCCC were onto it as early as March, and they tried to tell the world. And I see a deja vu with ivermectin, which I'm going to get into. Next slide. So to whom is this discussion geared? Now, I almost entitled this slide, "Who is this discussion geared to?" And then I remembered I'm speaking to teachers, and they would be really upset if I used that kind of poor grammar. So to whom is this discussion geared? I'm gearing this discussion to teachers who must return to the classroom for in-person learning, who are not vaccinated, have not been able to get vaccinated, either they don't want it or they can't get it. Basically, they're non-immunized, and now they are going back into a building with a bunch of breathing mouths in a global pandemic, and they are interested in learning in ways that they can protect themselves. Or if there's teachers who just, hey, it's a pandemic, it's Friday night, nothing else to do. If that's why you're here, welcome anyway. Next slide. The title of the talk, Eliminating the Fear, interestingly, that actually was not my idea, but I love it. I actually was the one, I'll give myself credit for coming up with the idea for speaking to teachers, because I remembered what it was like, going into an occupational setting where you were at risk, and I feel for you, and I want to try to disseminate the information I have to you to try to help you. Eliminating the fear does not mean that we don't take this virus seriously. We take it the utmost seriously. As I mentioned, we all do critical care. We see the sickest of the sick with this disease. There is probably almost no one who understands how bad this can get than we do. Eliminating the fear means that we believe, based on our appraisal of existing medical evidence, that we have a safe, effective, unburdensome, well-tolerated, and low-cost medicine that can be taken for people to protect themselves against contracting COVID-19 and or deteriorating and getting sick if you do contract it. This is not meant to replace protective measures, masks, hand hygiene, vaccination. It is meant as a bridge and a complement to these modalities. Next slide, please. So here's the iMask Plus slide. I'm focusing on the word prophylaxis. For those who don't know, means protection. Giving some kind of medicine or intervention to a healthy person to stop them from getting a disease or illness or syndrome, as opposed to treatment when someone who is sick with a process takes medicine to make them feel better. So I am really going to just focus on prophylaxis, because that is what I want to speak to teachers about in terms of how to protect themselves. iMask Plus, as Betsy mentioned, is a protocol that the doctors at the FLCCC selected And this is a sort of a key and core group of medicines that we can take to help boost our immune systems, keep our immune systems healthy, and stave off the ability of the virus to hurt us. Dr. Merrick, who's kind of the brain of the operation, has been doing tremendous work over the years with vitamin C. And vitamin C is a low cost, well tolerated supplement along with zinc, both important for immunity. Melatonin, I'll get into a little bit more, which is both good for promoting healthy sleep, which is important for the immune system, but also in of itself has antiviral properties. Vitamin D and ivermectin are of particular utmost importance and interest to me. I'm going to delve into those more. And then, of course, masks, keeping distance to the extent possible, and keeping your hands sanitized. Next slide, please. So there's sort of two main bifurcations that I want to get into here, which is how do I reduce my chances of contracting this altogether? And then if I do contract it, how do I minimize the likelihood that I'm going to have problems, meaning I'm going to get sick or clinically deteriorate if I do get it? So starting with reducing chances of contracting, and I was able, through being very careful and taking the right steps, to get through this whole pandemic in a very high risk setting without coming down with COVID-19. Eye covering. I understand if you're a teacher, wearing a face shield, it can be difficult for you to communicate with your students. I know you may be given them by your schools. Any kind of eye covering like goggles, or if you wear glasses, that's good. Masks, fitted is better than non-fitted. So you want things that loop around the ears, that can be pinched around the nose, and the better the fit, the better it's going to protect you. If you can get a KN95 or a 95 mask, those are going to be the best. And then you can do like a cloth over over like a surgical mask. The better it's fitted, the better for you. The fewer of your droplets are going to get to other people, and the fewer droplets that are going to get to you. So you want a well-fitted mask. Air circulation. And so this time of year, having windows open, the cold can be a rate limiting step there. If you can talk to your schools about what kind of HVAC methods they have there, but the more air circulating in and out of the room, the less particles build up in the room, the best it is for you. So if you can crack the windows for part of your lessons, or to the extent tolerated, always better to have more air circulating in and out. Keep your devices clean, your smartphone. You're touching it all day, you're touching surfaces, you're maybe putting it up to your face. You can buy little devices that use UV light, or you can use alcohol swabs, but keep your devices clean. Keep your hands clean, have a little hand sanitizer with you. Try to avoid touching your face. Choose what I call a hot zone at home. So if you have a garage, if you have a front foyer, a mudroom, something like that, if you don't live with roommates with whom you're not intimate, take your shoes off. Don't track things through your house that you're wearing at work. The more things you can remove and keep at the front of your house and not track through your home, the better. You want to follow your local public health guidance that you've been given, in all the education you've been given by your schools. Assume other people are carrying the virus and act accordingly. And physical distance to the extent possible. Now, as far as reducing your chances of getting sick if you do get the virus, so the four things that happen to us in the winter are what happens. We get a little pudgier, we sleep a little bit worse, we get a little bit more stressed out, and we become vitamin D deficient. And what are the four worst things you can be, other than age, which is a non-modifiable risk factor? The four worst things you can be if you get COVID-19 is overweight, underslept, stressed, and vitamin D deficient. And so first and foremost is you got to take vitamin D. And I understand if you read medical journals or follow medical news, there's been some controversy around that. It's safe, it's low cost, and we have abundance data showing that if you get sick with COVID and you're vitamin D deficient, you do worse. If you wait till you get sick and then try to take it, you don't get the benefit. So get on a vitamin D regimen. We're in the building during work hours. The sun comes down early. It's winter, the Northern Hemisphere. We're vitamin D deficient. Try not to use your phone before bed. And then really, almost even more importantly, don't check your phone right when you wake up in the morning. This really disrupts your healthy theta waves of sleep. You really need that restorative sleep. Try not to use sleep aids, what we call hypnotic agents, whether some people take NyQuil and some people take Benadryl and things like Ambien. And if it's prescribed by your doctor, do what you can do, but consider trying melatonin instead, because all those other sleep aids, they'll make you go to sleep, but they disrupt your ability to get good, deep stage 3 and 4 non-REM sleep, versus melatonin promotes healthy sleep, and it actually has antiviral properties. So it's kind of a 2-for-1. And, exercise, eat a healthy diet, and, stress relieving. Next slide. So I'm going to talk now specifically about ivermectin because you saw the IMS plus protocol and you might be thinking, what is this ivermectin stuff and what does this have to do with COVID-19? So just a quick quote from Francis Galton, which is, in science, credit goes, doesn't go to the man who, excuse me, credit, excuse me, credit goes to the man who convinces the world, not the man to whom the idea first occurs. And I think of things like the invention of the vaccine, which it actually started with smallpox, where this doctor in Gloucester named Edward Jenner noticed that milkmaids who were milking the cows were getting cowpox on their hands, which is really a limited skin disease, but they weren't getting sick with smallpox. And that became the basis for inoculation and ultimately vaccination, and the very basis of why we've been able to eradicate so much disease in the modern world. So these things come from unexpected places. Next slide. So riddle me this, Batman. In terms of medical breakthroughs from unexpected places, why is it that nursing homes that had scabies outbreaks did not have COVID deaths and had very few COVID cases? Scabies, for people who work with children, you probably know it's a highly contagious, very itchy and unpleasant skin condition caused by mites and eggs. What happens in an institutional setting like a nursing home or a skilled nursing facility is the patients who have come down with it and their contacts all get treated with this medicine, ivermectin. Next slide. So this is just a visual of a very interesting little study that was published of all places in a dermatology journal in France. And what they found was that there was this nursing home where there was this big scabies outbreak, and all these residents and staff members got treated with ivermectin. Now, the median age of these residents was 90. These are very old and comorbid people at high risk for COVID-19. Out of everybody there, only 11 people contracted COVID-19. Only 7 of the residents, 0 died. 1 needed oxygen, everyone else had mild disease. And in a matched group of nursing home residents from the region, it was more like, close to 23, 24% infection rates and 5% died. So it's a big difference that was statistically significant. And that was noted upon, that was noticed, and people took notice of that. Next slide. If that's not enough, there was another example in, in Toronto at Valley View Residence Nursing Home. So there was this big scabies outbreak, and there was also simultaneously a COVID outbreak. But the residents of the facility are the ones that got the scabies, and it was really the staff members that got the COVID outbreak. A lot of them didn't know it. This was in late February. This was a pretty amazing story. So ivermectin was distributed throughout the facility to the residents, but not to the staff. So the patients, the residents got it. And there was one floor, the 4th floor, that was really where the scabies outbreak happened. They got big doses of ivermectin. The other floors got smaller preventative doses. The staff didn't get it. The 4th floor also happened to have the most COVID infected staff out of any of the floors. And you have to understand, these are very elderly, very comorbid people requiring very close care. I mean, bathing, washing, eating, assistance with eating and drinking and walking. So the highly infected, unbeknownst to them at the time, staff members interacting with these very elderly comorbid patients, not a single resident living on the 4th floor was infected with COVID-19. Okay, not one became sick with COVID. There were only 6 infections in the entire facility. 4 of them were completely asymptomatic. Now compare this with how we know nursing homes were doing back then in general during this part of the pandemic. Next slide. So, okay, what does ivermectin, what is this medicine, and what does it have to do with COVID-19? It's a scabies drug. So it's actually a broad spectrum antiparasitic. It's been around for about 40 years, won the Nobel Prize because of its role in eradicating parasitic disease in the developing world. But it is also known to have potent antiviral activities against a range of viruses. It is also known to be a powerful anti-inflammatory drug. Next slide, please. In April, some Australian scientists decided to test it out. They infected some cells in a cell culture with SARS-CoV-2 virus, gave ivermectin to these cells, and found that they reduced the SARS-CoV-2 concentration by 5,000-fold. 99% of the virus was wiped out in 48 hours. This sparked some initial interest in the United States, but then there was some skepticism about whether this would translate to what we call in vivo. Would this become clinically important? Okay, there was a question about whether you could take enough of this medicine by mouth to build up these effects. And so a bunch of human trials kicked off worldwide, very few to none in the United States, unfortunately. So interest and attention in the drug in the US and Western Europe faded, but interest in Latin America, South Asia, and Africa did not. Next slide, please. So what happened is that, in higher developed countries, the doctors don't have a lot of experience with this medicine versus in lower and middle income countries, doctors and ministries of health, it ain't no thing. They give ivermectin easily, and they do these mass distribution campaigns where they give it to tons of people throughout the population to suppress the rise of parasitic diseases. And so countries like Peru, Brazil, India, Egypt, Iran, Mexico, and others, as soon as they saw even this minimal data, they just went for it, and they started mass distributing ivermectin to their populations. And in some of these countries, there were certain regions of health that did, or ministries of health in certain regions that did not do it, which allows us to have control in ivermectin areas. And the timings varied. And Western media was highly critical of these campaigns. There were all kinds of articles written in Nature and other places how this was such a bad idea and irresponsible. Next slide, please. Now, there's this gentleman called Juan Chamier, who's been a very, very close colleague and confidant of the FLCCC, who I happen to believe is going to go down historically as like the unsung hero of this pandemic. He's a data analyst, not even a medical data analyst, just a really smart data guy who accessed publicly available information about cases, hospitalizations, death, and he did these incredibly meticulous, really extremely well done analyses of what happened in all these different areas when ivermectin was mass distributed, comparing them to areas where it did not get mass distributed. And he accounted for every possible confounder you could think of. He used cell phone data activity to make sure that people weren't just all staying in their homes. He was noting people were aggregating more in areas of shopping and places like that. He was accounting for older people versus younger people getting infected. He did really meticulous work. What did he find? Next slide, please. So I'm going to let these images speak for themselves. What you have in the red there is deaths, and what you have in the blue is case counts of COVID-19. And these are all the individual states. This is within Peru. And in the gray area, that's before they did mass ivermectin distributions. And in the white is after. And you can see that the cases and the deaths plummet after they started the mass ivermectin distribution campaigns. And you can see in certain places like the bottom left, that cases in certain places did start to rise again, but the deaths did not. And the deaths dropped basically to pre-pandemic levels. And of course, at certain parts of the year, chronologically, we will just naturally see drops in death counts and case counts, but these were timed at all different times throughout the year, and they all had the exact same effect. They all timed out with the distribution of ivermectin, and we ordinarily never see plummets and drops that sharp. Next slide, please. This is really important. Here in red, you have Lima in Peru. In Lima, they did not use ivermectin. In all of these other areas in the different shades of blue, they did. Look what happened to case deaths in Lima compared to all the areas that used mass ivermectin distribution campaigns. Not even close. Next slide, please. This is Mexico. To the left is before July 31st, and to the right is after it. What happened July 31st? This one state in the bottom right called Chiapas did mass ivermectin distribution to all of their citizens. Red, orange, yellow, these shades mean lots of COVID cases, lots of COVID deaths actually. Green is a good number. Look what happened after July 31st. It just so happens that the one state in Mexico that did mass ivermectin distribution campaigns wound up in the green. Next slide, please. Paraguay. Alto Parana is a part of Paraguay that's represented by the blue. All the rest of them are other areas of Paraguay. Guess which one is the only one that did mass ivermectin distribution? Alto Parana. Look at the difference. Next slide, please. India. The state of Uttar Pradesh in particular did mass ivermectin distribution early on, and they had some of the lowest COVID case and death counts in the world. There was actually a time, there were days when they had not a single COVID death. But more recently, the entire country of India started these incredibly widespread mass ivermectin distribution campaigns. They sent it to households. People could go to kiosks and get it. They would have these little kits, and they would have ivermectin and zinc and some other things. And those of us who have been following this closely, the FLCCC and others, we saw this coming and we said, watch, the death counts are going to start plummeting in India. Even when they had their big religious pilgrimage festival and people were concerned that everyone was going to be getting together, we were going to have these spikes in cases. And you're starting to see all these reports from NPR and the Associated Press, the mystery of India's plummeting COVID-19 cases. What's India's secret? Something weird is happening in India. And Georgetown, my alma mater for college, one of their public health experts notes that they didn't start testing less, underreporting, none of that happened. ICUs are empty. It's a big mystery, versus those of us at FLCCC are just kind of like putting our palms to our foreheads because it's not a mystery. We know why this happened, but it just doesn't seem to be getting discussed that way. Next slide, please. Okay, I'll be quick on this part, and there are subsequent talks, and maybe we can do something else offline in the future, or you can refer to some of Dr. Corey's talks. But people like to see clinical trials in addition to this sort of large epidemiological information. Next slide, please. What do we have from our clinical trials? We've got dozens of clinical trials for treatment, both in the outpatient hospital setting. We're interested for teachers for what we call prophylaxis. Is this a medicine that I can take if I'm not even sick, if I'm healthy, that I can get this medicine in my system and it will actually protect me from contracting COVID-19? And or if I get COVID-19, will it make it more likely that I'll just have a mild course or not even feel it? That's what all of these studies are right here. And there's about 8 of them here. And this is a visual that we call a forest plot. And this is from what we call a meta-analysis. This is considered the highest form of medical evidence that we have. This is when you take a collection of studies and you look at the overall trends of the results. Multiple of these are randomized controlled trials, which are the highest form of individual trial we have. Others are what we call observational controlled trials. The number 1 in the middle indicates no effect. Anything to the right means that the drug made you worse. Anything to the left means the drug made you better. And when you get all the way to that second line there of 0.1, that's a strong effect. Look at how every single one of these clinical trials is lining up. Even with medicines we know has an established history of working well, we hardly ever see this in medicine. We hardly ever see studies lining up this consistently. What they did in these trials is there aren't any with teachers, but they did do them with healthcare workers. And so healthcare workers in COVID-19 going to work in places where they are likely to contract the disease, and they would compare people using PPE only to people using PPE plus taking ivermectin prophylactically. They found reductions up to 90% in some cases. In one study, out of 788 healthcare workers taking ivermectin, not a single one reported to get sick, versus the control group, close to 60% of them. Another couple of studies looked at household members of people sick with COVID-19, 87 to 88% reduction in likelihood of catching it from your household member if you're taking ivermectin, based on the trials that we have. Next slide, please. So we're wrapping up here. If ivermectin is really so effective against COVID-19, why have I heard much about it on the news? We got Sanjay Gupta and Tony Fauci here. I'll do my best to answer it, because I guess I can't say I know, but I think I know. The truth of the matter is this is a gigantic controversy within the medical community, which is common. Most of the time you have diverging and opposing schools of thought within medicine. But right now, the way that the media is behaving is that they are adhering to what the central health authorities are basically, in a way, giving them permission to talk about. And part of this is because there's been so much misinformation distributed and disseminated throughout this pandemic. But what I can tell you is that United States prescriptions are skyrocketing, close to 20 times higher since December. Numerous countries, not only is this permitted and recommended, it's part of the standard treatment protocol. Okay, the World Health Organization earlier this week signaled that they're going to be issuing recommendations around ivermectin soon. The National Institutes of Health, which is the big central health agency that really informs what we do, they basically went from red light to yellow light. So they were recommending against it. Once my colleagues presented this data to them, they went to what we call neutral, where they don't recommend for or against. This is actually pretty typical, unlike a traffic light where that goes from green to yellow to red, but then right to green. With big health authorities, usually you go from red light to yellow light. The next logical step is green light, and it's just a matter of time before they do it. The data is way too compelling. And the way that teachers grade papers, doctors and medical experts grade medical evidence. And the best experts with whom we've spoken that do this for a living, all they do is grade medical evidence. They are telling us that they have a moderate degree of scientific certainty that ivermectin reduces the likelihood of deterioration and death from COVID-19 by somewhere in the high 70s to 80%, and it might be somewhere between 60 and as high as 90 to 92. So there's really no debate over whether it works. It's just a matter of how much does it work. Moderate certainty is basically like a B plus. Okay. So why aren't we hearing about it? Well, we had a lot of things early on in the pandemic that we thought were going to work that didn't. That was like based on C minus evidence. And now the way that the medical community and the media have reacted is they're all waiting for the A plus. The A plus is the ever elusive multi-thousand patient per arm double-blind placebo-controlled trial. Unfortunately, the government research agency hasn't funded them, and we've been relying on smaller randomized trials, but we've compiled the data and we have at least B plus to probably A minus certainty evidence that ivermectin can protect you if you take it from getting sick from COVID-19, on top of the other protective measures that we already talked about. Okay, so and there's really no historical precedent in medicine to insist on A plus level data before we act, especially with medicines that are really safe and have been around for a long time and not expensive. Most of our guidance in medicine comes from like C level evidence. Next slide, please. Who should not take ivermectin? If you're either thinking about becoming pregnant or pregnant, there's some evidence there might be some birth defects associated with it. If you take the blood thinner warfarin, you should talk to your doctor. It can interact. If you have a history of organ transplantation, you might be on medicines that could interact with it. If you have any history of anything that could have damaged the brain or the blood-brain barrier, like bleeds or radiation treatment above the neck, things like that, that's something you should talk to your doctor about. Really, anything else, though, there's no contraindications. Even people that have late liver and kidney problems, it's very well tolerated and very, very, very safe. Next slide, please. This is the last slide. Where can I obtain a prescription for ivermectin? So you can ask your personal physician. I would suggest going to FLCCC.net and printing out the manuscript from Dr. Corey, and you can the protocol, the IMAS Plus, and give it to them, because doctors like protocols. Doctors like to read evidence. A lot of doctors are familiar with it, but a lot aren't. Your doctor might say no, and if you're still interested in it, there is a link on the FLCCC website with a directory by state, and you can find telehealth prescribers who are prescribing it, and that's how a lot of people are obtaining it. I've been giving it to friends and family of mine, patients that have come to me, who are concerned in their work settings where they're worried they're going to get it. My anecdotal observation is that people have been doing phenomenally well with it. People who are taking this medicine are getting it at most mildly sick, and that's my experience with it. So that's what I have, and I'm sorry if I ran too much over, and I guess we should take some questions.
Yes, and we have a number of questions that follow up really on that whole issue of how do I get it, and if my doctor won't prescribe it, which you talked about. But we even have an anonymous attendee here who said, yeah, but my local pharmacy said it wouldn't even fill a prescription for ivermectin, and it is not authorized for COVID. What can I do?
Okay, so that actually, Dr. Corey actually put on the FAQ, frequently asked questions, on the FLCCC website. Pharmacies are not allowed to do that. That could actually be construed as practicing medicine, which pharmacies are not allowed to do. Pharmacists and pharmacies are allowed to use discretion if they feel the doctor is prescribing something completely untoward, unsafe, or toxic, but they cannot take it upon themselves to decide that they're not going to fill something. And as a matter of fact, the NIH does list ivermectin in their treatment, in their list of medicines, with a neutral recommendation. There are protocols. You can tell that pharmacy that you are going to call the board of pharmacies if they do that. You can call your doctor and ask your doctor to speak to that pharmacist. I've run into some of these issues. They back down. They are not allowed to do that.
We have Julia Long said asked another question along that line. She says, I asked my GP if he'd prescribe it. He said doctors would get in trouble if they did. Now that was 3 weeks ago. How do we deal with that?
So that's a myth. I mean, unfortunately, again, I mentioned the pendulum swinging so far the other way. Doctors have authorization to prescribe medicines, what we call off-label. In fact, it makes up about 20% of medical practice. That doctors using medicines that are FDA approved for one condition, that have demonstrable safety, and using them to treat other conditions. This is why we go to medical school and study pharmacology and pathophysiology, because we know these things. And no, you cannot get in trouble as a doctor by writing medicine as you see fit. A lot of doctors get very nervous and they worry about their liability and they worry about these things, whereas most of us try to promote putting the patient first and thinking about the patient. This is disappointing to hear. That I don't know if that's a GP that sounds like they're going to go on board with it until they get a full blown green light from the NIH, which is probably coming soon. I would probably refer you to the directory of telehealth providers because you're more likely to find a more reasonable GP.
I think our doctors generally expect that the World Health Organization is more likely to move first before the NIH on this.
It'll be the WHO, but again, the NIH has already given it kind of a yellow light. What we're expecting between the next 4 to 6 weeks is that the World Health Organization is likely going to be giving it a full blown give it. Because again, I mean, the data is just so compelling that I just can't see it going any other way. And they're kind of already hinting and signaling at it. So yeah, we expect that. And I think once the WHO at least gives it the nod, I think most doctors will then start following suit.
And maybe the media will cover it then. I used to be some people know that. They've been remembering me from CBS that maybe they'll actually get onto that then. We're trying to get it there. Here's a question from Deb Gluskin, which deals with dosages. Says, I've been taking 3 milligrams 3 times a week of ivermectin for a few weeks, just bumped up to 3 milligrams 7 times a week. I'm sensitive and have to work up. Will it still work as a prophylactic for COVID while I work my way up to your recommended dose? And after your recommended time frame, do you suggest a maintenance dose in the future? I think that sounds a little high for what's our protocol, doesn't it, to you?
So I'll start by saying, I can't give specific medical advice, but what I would say is that the pills come in 3 milligram pills, but the dosing is 0.2 milligrams per kilogram. So let's say somebody that weighs 130 or some odd pounds is about 60 kilograms. That's 12 milligrams. So that's 4 tablets. So you would want to be taking about 4 tablets a week. If you're somebody who's bigger, yeah, it might be about 7 tablets. But spreading them out day by day doesn't really make much sense. You want to take it and you want it to build up in your system. So that's the better way. Taking a 3 milligram tablet just once is not a good way to build up enough of it in your body to work. It has to really build up in your lung tissue and in what we call your adipose or fat tissue to protect you. That's where all the receptors are that the SARS virus likes to bind to. You want this to build up. You also want to take it with food, like healthy fats. This is what we call lipophilic. It likes to move into fat. So have a meal that has some good healthy fats and take the medicine with that kind of food, and you're likely to build up enough to protect you.
We have a couple of questions here about some of the data. Do we have any COVID numbers for Africa where ivermectin is widely used?
Yeah, I don't have the exact figures, but we know that compared to countries that are not using ivermectin, and so there was actually a study published very early on in the International Journal of Infectious Diseases that compared countries that were using it for parasitic diseases to those countries that don't, and the numbers of cases and deaths are way lower in countries that use ivermectin widely compared to countries that don't. I mean, we've known that since the beginning of the pandemic.
And here's another question. Timothy Cook wants to know, says, do you know if that one Mexican state that has so low COVID cases because they're using ivermectin, why isn't the rest of Mexico following suit?
Well, now they are. Remember, that was from July. Now they are. So Mexico is now one of the numbers. So there's I don't know if it's a dozen. We have Greece, Iran, Egypt, North Macedonia, Slovakia, Bulgaria, Argentina, Mexico, Honduras, Belize. I think I mentioned Greece, Egypt, Iran. There's countries all over the world that are using this standard now. India, Pakistan, and another couple. So Mexico now is using it, and we are already starting to see pretty massive and drastic drops in cases and deaths since they have been.
Brianne Larkin has a good question here. What alternative on the protocol can be offered to those who are pregnant or hoping to get pregnant?
That's a tough one. To the best of my knowledge, there's no reason why someone who's pregnant can't take like vitamin supplementation, but I would have to refer you to your OBGYN before I can give you any medical advice if you're pregnant. It's a little out of my wheelhouse. I don't want to give any incorrect information, but I can't advise somebody that's pregnant, particularly early on, to be taking our ivermectin because of what we call potential teratogenicity, meaning could be theoretically associated with birth defects. But yeah, as far as I know, there's no reason not to be taking vitamin D at the very least. And I'm not aware of any reasons why people couldn't take things like zinc, vitamin C, and but I would talk to your OBGYN about that, bring the protocol to them and run down it with them and see what they have to say.
Here's a good question from, I hope I say this right, Linder Singh Jawanda. How to protect in a classroom where the mask is a problem to talk through?
Okay. Well, I mean, the mask is kind of a must, right? You're talking to somebody who has to take full medical histories from like 80-year-old people with hard of hearing through an N95 in a surgical mask and a face shield. So I feel your pain, brother. Um, it's I think you really just want to try your best to enunciate. And if you can use parts of the day where you're just using the single surgical mask, and when you're talking less, maybe use that. And when the problem is, the more you're talking, the more droplets are coming out of your mouth, and the less talking, the less droplets coming out. So if you're using less masking when you're talking more, you're putting students more at risk. I guess I don't have a great answer for that. I guess we've kind of all managed to do it. Enunciate, gesticulate, use pictures.
Oh yeah, we have someone is asking, can ivermectin be used? This is Sylvia Iverson. Can ivermectin be used for patients with a compromised blood-brain barrier?
No. So on that last slide, I mentioned that no, you probably shouldn't. And again, you can talk to your own physician about that, but that is one area where I would be very cautious, because the great thing about ivermectin is that it's a molecule that is designed to kill you if you don't have a backbone. So it's deadly to invertebrates, very safe for vertebrates because of the way that it binds to receptors. The one exception is if it gets into the brain of even a vertebrate, the receptors that it can hook on into the brain can be very, very sedating, and it can cause major problems. The good news is it doesn't get through the blood-brain barrier, which is why it's safe for ordinary people. But if you do have compromise to your blood-brain barrier, that's most likely going to be a no-no.
Someone wants to know, anonymous, do we have evidence of safety and efficacy for school-age children taking ivermectin? It says current estimates for vaccination for elementary school-age children are perhaps up to a year out from now. What about children?
Yeah, so I am board certified in adult internal medicine, so I'm not going to get into any advice on medication for children. What I can say is that it has been used historically for children. I think because children are at much less risk to have serious complications with ivermectin, and it's not unlimited, that giving it to children prophylactically probably doesn't make a ton of sense. I think it makes more sense for adults to prophylax with ivermectin. As far as can children be treated if they get infected with COVID, it's not really the focus of tonight's talk, and it's not something I want to get into just because I'm not a pediatrician.
I will only pass along something. I interviewed a pediatrician just the other day, and she said that she had treated children and infants, infant as young as somebody 10 months with ivermectin with no bad side effects. So
that's my understanding of it, but I just can't speak to it because it's not my specialty.
Here's the last question that we have time for. How can we as teachers help to bring this information forward to our school systems?
That's a great question. Talk to whoever is the head honcho and give them the paper and ask them to read it. I would say print the protocol, refer them, I guess to links to Dr. Corey's videos, to Dr. Marek's videos, and ask them to please watch and educate themselves. The more they read and educate themselves, the more they'll know about it. So I think just passing the data to them, the information's all there. It just has to get disseminated. And this is why I felt so compelled to do this tonight, is because we're sitting on this information, and I felt like if teachers all go back to school and you're not hearing about ivermectin on the news, they can take this medicine and really protect themselves. So in the spirit of me wanting to disseminate this information to you, you should disseminate this information to those people, the school boards, your principals, whoever, and have them read about it. And because the more people read about it, the more likely they are going to be to implement and recommend. It's not like they can prescribe it to you, but it should be part of education.
And we thank you, Dr. Osgood. And, that's all the time we have for now. We're sorry about that, folks, that we run out of time. We will, however, this is being recorded. It will be on our website. The website is very simple. It's https:// FLCCC.net. You'll be able to find it there forever. It's, I think we'll probably even send links out on social media. We have FLCCC Facebook, we're on Twitter, we're on LinkedIn. So you'll probably be able to get links to this to share with other teachers. Yes, it'll be there. We also will tell you that some of you, if you have questions, I know somebody asked a question about long haulers. We also have a video on long haulers that we just did Wednesday night. That's on the website, has a lot of questions about that. Surprisingly enough, ivermectin works for long haulers. So, but you can check out that entire talk from Wednesday night that is on the website. We will be back this coming Wednesday night. We're doing regular weekly updates now with our different doctors to answer your questions about treatment, prevention of COVID, getting through this pandemic, because that's what this whole group came together for. And we are passionate about putting people first. And that's it for now. We want to say thank you for watching. As I said, Wednesdays, 7 p.m. Eastern, 4 p.m. Pacific, and whatever it is in between. And come back, talk to us. Oh, and one other thing, we'd like to have you join our FLCCC Alliance. You can do that on the website. We have a network and support page. Just go there, you can sign up, you can get regular emails from us on whatever is new, whatever is happening. And there is a wealth of information. There are lots of videos on the website from people who have been treated and have recovered with our protocols. You'll be amazed and heartened as we have been. This is all about saving lives. We're all about putting patients first, putting people first, and that's what we're going to be doing while we're off air. Thank you so much, and we'll see you soon.